Good afternoon, everybody. Just giving everybody a few minutes to get logged on. I'm seeing we're getting a couple of participants joining. I'm just going to wait for that to level out and then we'll get started. Okay. I think we're pretty stable. I'm going to start with just introducing myself, and people are going to keep rolling in, and I'll answer questions as we're going through. My name is Dr. Kristi Maas. I'm a reproductive endocrinologist at Reproductive Care Center. We have satellites in Sandy, Utah, as well as Clearfield, Utah. And then we actually provide medical care for people throughout the Rocky Mountains. So I have patients in Wyoming, Idaho, Montana, Nevada, Colorado, you name it. So living in the Rockies, we've learned that we need to travel for specialty care. And it's really nice for me to be able to provide that care back to my home state of Wyoming. We're going to pop into just a couple of questions, and I'm going to keep an eye on everything as we're going through. We had a couple of questions that were submitted preemptively, and that'll let everybody get a few minutes to get their questions in the chat box. But the first one is, how long does it take for an egg freezing cycle, or essentially a fertility preservation cycle for eggs? And it takes about 2 weeks to grow an egg. And this is whether it's in nature on your own with your own body, or using Clomid or letrozole, also called Femara, or if you're using the injectable medications for egg freezing or IVF. That growth phase takes it from an immature phase to what we call a mature oocyte, or an M2 egg that has divided the 2 sets of DNA that each of our cells have in it, so that it could either be fertilized by sperm or frozen for future use. In general, most people have a little bit of a preparation phase to get into treatment. And then after egg extraction, after ovulation, which is kind of natural release of the egg versus mechanical release of the egg, our menstrual cycle starts, our period starts about 2 weeks later. All of our fertility treatment really follows a menstrual calendar, so it's kind of month by month, whether it's Clomid, whether it's letrozole, whether it's IVF or egg freezing or embryo transfer. First question we're popping up, let's talk a little bit about breastfeeding during IVF and during an FET. The main considerations we have are that very often patients are on hormonal medications that could be excreted in the breast milk that we wouldn't necessarily want to be exposing our newborn children to. Additionally, breastfeeding back in cave people days, cavemen and cave women days, that was our original birth control. That's how we were, caring for our newborn child and not achieving a pregnancy. So we have a baby in arms and a baby in belly, and we're being chased by a saber-toothed tiger. It actually raises a hormone called prolactin. This is released from the pituitary gland in our brain. If you put your tongue all the way on the top of the roof of your mouth, there's a little gland on the other side of that bone. It's about the size of the tip of your pinky. And that's what releases the prolactin. And that's actually what causes breast milk to be excreted. This is a hormone that can be associated with multiple miscarriages or irregular menstrual cycles. That's why our periods go away when we're exclusively breastfeeding. So when we're trying to achieve pregnancy, that's something that we want to avoid as much as able. Hopefully this answers your question. We're going to move on to the next one, which is if there's a difference in pregnancy with taking a trigger shot, such as Ovidril, Novaril, with your treatment, or if you're just using your ovulation predictor kits and you trigger on your own. And there actually isn't. It's just a matter of what's causing you to ovulate your egg. Now, clearly, if you don't ovulate an egg, you're not going to get pregnant, never create a pregnancy without an egg. But the real question is whether you're getting the surge, which is a hormone called LH, also produced from that pituitary gland in your brain. You get that surge either from your brain itself, or the trigger shot acts like an external mimic of what your brain is releasing to get you to ovulate an egg. Either way, as long as you ovulate, your chances of achieving pregnancy are based on egg release and sperm exposure. We'll move on to the next one and talk about age and fertility, and kind of about how that impacts our decision-making for IUI treatment, and maybe even a little bit more for IVF as well. The question is, how many mature follicles would you cancel an IUI cycle with for a 30-year-old versus a 35-year-old? And this question really targets the heart of what the strongest determining factor for fertility is, which is egg age. At age 35, about half of the eggs are going to be abnormal genetically or chromosomally, meaning they have extra or missing chromosomes. At age 30, maybe a third of them are abnormal. Generally, if I'm doing medicated IUI cycles, I'm looking for a 2 to 4 follicle or egg range in my patients that are going through medicated IUIs. Now, there is data that patients that are older, so those patients that have over half of their follicles and eggs expected to be abnormal, they should move on to more advanced treatment like IVF sooner rather than later. Boston IVF completed a study called the 40 trial. It's FORTT, and they looked at 38 to 42-year-olds, and they said, hey, should these people go through IUI 3 times and then IVF if they're not pregnant, or should they go to IVF first? And that data actually supported going on to IVF first because more of the eggs are expected to be abnormal. So you're going to need more eggs to get to the genetically normal egg that you can put with sperm to create the embryo, to create your baby. So I would say between 30 to 35, I'm still looking for the 2 to 4 range. I don't really love a 30-year-old having more than 4. 35-year-old, I think more than 6 makes me pretty uncomfortable. Even with a genetically normal egg and a genetically normal embryo, that's IVF and preimplantation genetic testing, we're going to be in the range of 50 to 60% chance of pregnancy per genetically normal embryo. So that unfortunately doesn't even guarantee a pregnancy, which is why we could have 2 of those and still not have a high risk of having things like twins. Our real concern is triplets or quads. Depending on what agents you're using for medications, those are unlikely with medications like Clomid or Letrozole, also called Femara, which are your oral agents that we're commonly using for IUI. Less commonly, we're using injectable agents like FSH mimics or LH mimics that are more often used in IVF. Let's move on to the next one. If you have low, I'm assuming egg supply, and did a cycle for egg freezing and only had 1 egg frozen, but 5 were seen, would you recommend another cycle? And I think this really is a personalized discussion that you want to have with your reproductive endocrinologist who took you through the treatment, and based on their findings and based on your age. As I had mentioned, age is the strongest determining factor for fertility. So if we're getting 1 egg at age 20, that has a much different reproductive potential than 1 egg at age 40. And so you've got to really take into consideration what your family building goals are, what your age is, and what your statistical probability of success is. There are some calculators that can estimate that. There's a calculator actually from Brigham and Women's Hospital called the Egg Freezing Counseling Tool, or EFCT. I use that a lot for patients and use that to guide some of the decision making. For example, I had one patient with a low AMH who ended up going through 13 cycles of egg freezing to build up enough eggs for their comfort level to achieve the family size based on the statistical models, understanding these are only statistical models. That said, how you're going to perform in a fertility treatment cycle, such as IVF or egg freezing, we can estimate with things like your AMH hormone level, which is a blood test, or your antral follicle count ultrasound, which is a transvaginal ultrasound. But the most predictive factor is how you've done in a prior fertility treatment process. So I would encourage you very much to have a follow-up with your reproductive endocrinologist, and even consider a second opinion if you want to get another perspective, but have someone review your whole case, have someone review you as a person, your stimulation and your retrieval numbers to give you a personalized approach to your treatment. Next question. If you have a low AMH and you're young, is that synonymous with infertility? It seems like that's what this person is asking. And actually, it's not. So AMH is a blood test that gives me an idea or an assessment of egg supply. It tells me, do you have a lot of eggs left, a medium amount, or a small amount? It doesn't give me an absolute number. So I'm not going to be like, you have 2,227 eggs left. But it gives me an idea of what we have to work with as far as fertility treatment. So if you have a low AMH, I'm probably not going to get 30 eggs from you if I take you to IVF. If you have a high AMH, then the upper limit is going to be a higher range for egg level. Unfortunately, everybody going through 0 is the lower end of the spectrum because it doesn't guarantee that you'll get eggs, although the majority of people do that go through treatment. That said, AMH does not predict your ability to conceive when exposed to sperm. So there are patients that have very elevated AMH levels, and they've been trying for 5 years and they're not achieving pregnancy. There are other patients that just get an AMH randomly checked as a fertility check, which actually I don't think of that as a fertility check. And the first time they're exposed to sperm, they're pregnant like that. They're perfectly fertile. Fertility is defined as sperm and egg exposure, creating a pregnancy, or infertility, sperm and egg exposure, not creating a pregnancy after a year if you're under age 35, after 6 months if you're over age 35, or if there's a risk factors where we don't think there's sperm or don't think you're releasing an egg, or we have other health concerns sooner, that's when we start the assessment for things. We're going to go a little bit more to embryo transfer questions. This is frozen embryo transfers, I'm assuming. This is after the transfer of an embryo, of a genetically normal embryo, I'm assuming, when there's failure for that embryo to implant, what could be the potential causes? And this is actually very, very broad because this requires the right embryo, this requires the right environment. That includes the uterus, the lining of the uterus, the anatomy, including things like fibroids or polyps or scar tissue. And then it also involves whole body health and well-being. So environmental exposures to toxins, let's say smoke or alcohol. It involves general health and well-being, heart disease, liver disease, thyroid disease, those types of components. But circling back, remember I said that with a genetically normal embryo, we're looking at about 50 to 60% chance of achieving pregnancy. So having a genetically normal embryo does not guarantee implantation, nor does it guarantee live birth or a baby. So unfortunately, if we have one and it doesn't work, it's not a panic. It's unfortunate. It's not what we're hoping for, but it's not panic time. It's not time to, look at a surrogate or look at donor eggs. We need to give it another go. Now, one of the more recent studies said after 3 genetically tested and genetically normal embryos, we would expect 95% or greater of patients to achieve a live birth. So if you've transferred 3 genetically normal and you're not pregnant, then yes, then you're falling off of our population statistics and our expectation. Hopefully that's somewhat helpful, though there's so many potential factors that go into achieving pregnancy that an isolated failed implantation doesn't give us the full answer. And very often I don't have the full answer for you. And we'll circle back to the second part of that question in just a minute. I'm going to kind of go through to make sure that everybody else gets questions answered. So how does having hypothalamic amenorrhea impact your treatment and your potential outcomes? And are there specific risks or considerations? So for those of you that don't know what hypothalamic amenorrhea is, that's where that pituitary gland that we talked about earlier is not secreting the hormones that it normally does to stimulate the ovary. And that can be because the levels are too low, or it could be that they're kind of speaking a different language. They're trying to give instructions in German and the ovary's understanding in Spanish, because the hormones are released in a pulsatile fashion. And the pulse frequency and amplitude delineates how the ovary responds. You can have too little just at baseline, or we're just not communicating in a way that the ovary is understanding. Now, in these situations, it depends on the cause of it. Is it that it's just not communicating well? If that's the case, we can add medications to try and get them communicating, kind of a translator per se. If your brain is not naturally releasing these hormones, then you need to self-administer them. And these are injectable forms. These are the medications that we commonly use for things like IVF. They are a pharmacologic mimic of FSH, or follicle stimulating hormone, from your brain, as well as LH, which also comes from the brain, the pituitary gland, for both of those. The risk, if you're doing the injections and things like timed intercourse or intrauterine insemination, also called IUI, is that generally people that have these low hormone levels still have very robust egg supply. And so you have to be cautious not to overdo it. As I mentioned previously, we don't want to have you ovulating a gajillion eggs and having your own reality TV show and octuplets and things like that. And I kind of joke, don't want someone to take my medical license because I'm creating unsafe pregnancies, because I love what I do. So you have to be delicate with your titration of the doses of these. It can often be very frustrating for patients because we have to keep a close eye on them to make sure that they don't over respond and get into an unsafe situation. And sometimes it takes a long time for the ovary to wake up. So very often for the first treatment cycle, it may be a month of injections before we even really get that egg growing in the ovary. Now, as far as pregnancy-specific risks, there's nothing that increases your risk carrying a pregnancy or anything like that. That said, our goal is for you to carry one baby at a time. That's how we evolved as a species, to ovulate one egg a month, carry one baby at a time. Let's talk a little bit about exercise. This is one of my favorite things to talk about, because it personally, when I was going through my egg freezing process, which is essentially the first half of IVF, that was the biggest challenge for me. I was training for marathons, running quite a bit. And as you're stimulating your ovaries with the injectable medications and growing them larger, we want to make sure that you're not doing high impact activity, meaning bouncing, running, jumping, as well as no inversion. So that's things like headstands, downward dog, a lot of the yoga poses. In a worst case situation, it'd be like gymnastics. Please don't do that. And that's because the ovaries, if you think about our models, they always have them kind of sticking directly out from the uterus. But in reality, they are on a soft tissue ligament, and they can move quite a bit. And in that movement, if they are getting enlarged, they can be top heavy, they can spin on their ligament tether. And if they twist, that's called torsion, and that can be a life-threatening emergency or an ovary-threatening emergency where we need to go and untwist it to try and get blood supply back to the ovary. That requires surgery. If you didn't untwist it and it started to die, that clearly damages your ovary. And if the ovary started to die and you had dead tissue in your abdomen, that could lead to severe infection. Now, these are highly unlikely. Within my career, I've never actually had a patient do this, but we also counsel our patients to avoid the high impact activity and the inversions. Additionally, we recommend no intravaginal intercourse, because that can also move the ovaries, and no sperm exposure, because when we do the egg extraction, when we get any egg that we can safely get to, Hopefully we get to get to all the eggs, but there is the potential of getting to a space that you can't safely access an ovary. And if that is the case, then you could theoretically have a multitude of eggs floating around. We wouldn't want to have sperm exposure during that time frame and create an unplanned multiple pregnancy with high numbers of pregnancies in the uterus. So main restrictions: no sperm exposure, no high impact activity, no headstands, no inversions. But good luck with your process. I'm sure you will do fantastic. Take good care of yourself. I'm a huge advocate for self-care, whatever that may be. A walk, if it's a cup of tea and a good book, do whatever you can for good self-care during this process. Let's talk about candidacy for carrying a pregnancy. Who's a good candidate? Someone with PCOS or someone that is older? So our pregnancy risks do go up with age, and PCOS does have risks to our general health and well-being. So PCOS stands for polycystic ovarian syndrome, which actually I really hate the term. It's not that these people have a bunch of cysts in their ovaries. It's actually a bunch of potential eggs. So their antral follicle count ultrasound, they have a ton of antral follicles. But PCOS does have an association with elevated risk for high blood pressure that's inside and outside of pregnancy, diabetes inside and outside of pregnancy, and high cholesterol. It also can be associated with an elevated BMI. And we do know that elevated BMI, diabetes, and high blood pressure make things a more complicated pregnancy. That said, if you are a healthy person that's younger with PCOS, you would potentially be the better candidate, versus if you are a young person with PCOS with a really bad high blood pressure, poorly controlled, or diabetes on injections, versus the 39-year-old that's perfectly healthy, then the 39-year-old may be the better candidate for carrying a pregnancy. So I think this is an important discussion, just to look at the whole health picture, not just age. And we do know that PCOS is a risk factor, age is a risk factor, but I have ample numbers of humans that are 39, as well as those with PCOS, that safely carry and deliver a pregnancy. And I think some of this is also just questions about how you hope to build your family. You know, some families, someone feels very strongly that they too want to carry pregnancy, and the other individual doesn't. And you have a discussion with your healthcare provider, see what the safest approach is, weigh that out for the individuals involved, and see what fits you correctly. I'm going to pop to one of the shorter ones so that I can kind of visually keep an eye on the other ones. But left ovary follicles, is one side better or other? No, equal. So some people do have a dominant ovary that tends to ovulate more than the other ovary. So you may go right, 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 left, or left, right, left, right. That doesn't mean that one side is good and the other side is bad, nor vice versa. Additionally, they looked at people who had only one ovary on one side and a fallopian tube on the other side, and they found that about a third of the time your opposite tube will pick up your egg. So for those that only have one tube, don't panic. You have chances to get pregnant whether you ovulate on that side or the other side. But there is not one side that's better than the other for follicles, for ovaries. And additionally, you wake up about 1,000 eggs every single month. On your own, generally, we select one. It's growing in something, we call it the dominant follicle, and that follicle ruptures. So we actually rupture a cyst to ovulate an egg. And the other 999 die, and we don't get to use them. So fertility treatment is aimed to rescue some of those 999 that would have otherwise have died from dying off. So it doesn't damage your ovaries, nor deplete your egg supply. Our body is not great at choosing the normal or perfect egg first. Otherwise, our human reproduction would be much more efficient. At best, we're 22% chance per month at age 20. That's as good as it gets. If we always ovulated the normal and good egg, then we would be much higher. We'd be well above 50%. And again, some people have a dominant ovary that doesn't correlate at all with our quality of our eggs. And we're talking population statistics. So when I'm talking about, at 35, half the eggs are normal, half are abnormal, that doesn't mean 50-50 every single month of that 1,000 that wake up. One month we may have 80 that are abnormal and 20 that are normal. And the next month, it may be the other end of that. So it does vary from group of eggs to group of eggs. Let's go to how long can a frozen embryo be stored? Theoretically, indefinitely. That said, our newer freezing process called vitrification, and I use newer loosely, this came to fruition back in the early 2000s. It's a much more efficient way of freezing embryos than our quote unquote slow freezing that we did back in the beginning of IVF. And the best analogy I have to describe these for anybody that enjoys a cocktail, if you think about like the beautiful, pristine, clear ice cube without any ice crystals or anything that you see in a Scotch cocktail, that tends to be something that I think more of as a fast vitrification freeze. It's pristine, there's no crystals, there's nothing in it, versus the old icebox 1970s ones that you had to like twist sideways to crack and break that were basically white because there were so many ice crystals in it. Those are the main difference between kind of a slow freezing process and a flash freezing process. And those ice crystals can actually damage cells. So that's where our freeze-thaw survival with our older slow freezing with more ice crystals is lower than our flash freezing that we're currently using for embryos and eggs. But yes, theoretically indefinitely, and it'll have the reproductive potential of the age when you froze it, even if you come back 20 years from now to use it. We can actually take a menopausal uterus and make it carry a pregnancy by giving up hormones. So they are fertility preservation. When you go through an IVF process, it could be three potential things. It could be infertility treatment, meaning you're getting pregnant, that's the goal. It could be fertility preservation, meaning, hey, we freeze anything that's surplus and it has the reproductive potential of your age at that time that it was created, even if you use it down the road. And occasionally it can be diagnostic where we uncover something that we couldn't see without putting the egg and sperm together in a petri dish. I don't hope for that. Usually it's bad news if I'm uncovering something during the process. It's like, hey, the eggs didn't look like I expected, or they didn't fertilize or didn't develop in a way that I expected just from the outside looking in. I'm going to read the next question because it's long enough. I couldn't kind of catch all of it. So someone who is going through IVF with advanced reproductive age in their 40s, and they have a genetically normal, beautiful embryo from their cycle. That's great. Congrats. And they want to try and do another cycle so that they could build their embryo inventory. This next cycle didn't yield as many eggs and they're still waiting. Would I recommend ERA testing given that there is only one embryo and they don't have any pregnancy history or anything like that? So ERA is something that we call an endometrial receptivity analysis. And this is a biopsy of the lining of the uterus that we take when we would normally put an embryo of the uterus. So people will call it a mock cycle. You expose the lining of the uterus to estrogen, then you expose it to progesterone, and you take a biopsy of that lining and send it off for genetic analysis to see if it's quote unquote receptive. And this is something that when it first came out, we were very excited. We're like, yes, this is going to tell us if the uterus is ready for an embryo. It's going to be perfect. I did a bunch of them with the data when it first was coming out. We were very enthusiastic about it. And now that we have more data and larger studies, it unfortunately is not shaking out that this is revealing in a way that is helpful for embryo implantation. My background, I'm an engineer, and I've always struggled with the fact of this is synchronizing. and we're synchronizing the uterus and an embryo. But we're synchronizing it down to an hour based on the ERA, and it's plus or minus 3 hours. So it gives you kind of a 6-hour window. But we're not accounting for any component of the embryo. So an expansion grade 4 embryo is not necessarily on the same timeline as an expansion grade 5 embryo. And when we look at that, I've always struggled with, well, we're only synchronizing half of the equation, so it doesn't really account for the embryo component. And I suspect that's part of the reason that this really isn't coming to fruition to be helpful. I don't think it's hurtful for people to do an ERA, but the data is not supporting this being beneficial. And I will say that it does take you a month to do that. If I were counseling a patient in your shoes, I would actually have them spend their time, their finances, and their emotions considering another cycle of embryo creation rather than ERA. Let's talk about the name of the Boston IVF study in the 38 to 42-year-olds. It was the FORTT trial, FORTT trial. And then there's another one that they looked for unexplained infertility called the FAST trial, FASTT trial. But really, I think you're looking at the FORTT trial to answer your question there. Do I need to cancel a cycle because of cysts? What is a corpus luteum cyst? So this gets really back to basic menstrual cycle biology. Remember I said we had about 1,000 eggs that wake up each month. One of them gets selected to grow in a fluid-filled area called the dominant follicle. And then this follicle ruptures, it's a cyst rupturing, and the egg is released, causing ovulation. After the egg is released, where it was released from in that dominant follicle becomes what we call a corpus luteal cyst. This cyst secretes estrogen and progesterone. If you become pregnant, the pregnancy hormone maintains your corpus luteal cyst. So the HCG from your pregnancy supports that corpus luteum producing more progesterone. And it'll do that through about 7-8 weeks of pregnancy. So that corpus luteum will stay in place. If you do not achieve pregnancy, then it is not exposed to the pregnancy hormone. And it actually is designed to disintegrate. And so it starts to dissolve, and that corpus luteum dissolving drops your progesterone level. And the progesterone drop or withdrawal is what actually induces your period. And so if someone is starting a cycle and they still have a corpus luteum in place, then that would not be kind of the baseline phase for you to be starting the next step of your treatment. Let's talk about CoQ10 and quality and quantity with egg freezing. So coenzyme Q10 is also called ubiquinol. It is something that supports the mitochondria or powerhouse of our cells. Sometimes competitive athletes will use it. And there's some data that in mice, coenzyme Q10 may help with the quality of our reproductive gametes. So things like sperm and egg. Now, when I think about the duration that mice were on it versus the timeline for human reproduction, it's hard to directly extrapolate that out because it's years, and we know that we lose quality and quantity with time in humans as well as mice. But it certainly isn't going to hurt. If I'm going to recommend one supplement to try to support egg quality, I generally do that with the coenzyme Q10. I think there are some people that it may help stave off the aging process and others that it doesn't. Our current understanding is that we're born with every egg we'll ever have, and that quantity and quality declines with time. So when we think about being born with everything that we've ever had, anything that your body's ever been exposed to is something that all of your eggs have been exposed to. I don't think of CoQ10 as having the ability to take an abnormal or bad egg and make it good. I just think of it as staving off the aging process. I also don't think of that necessarily improving the number of eggs you're going to get with an egg freezing process. I think that depends a little more on your stimulation protocol and how we're approaching that. Let's talk. I'm going to try and circle back to the second part of the first question. So there's a question about birth control taken from a fertility treatment cycle and whether that has an impact in embryo implantation. And if you don't bleed very much with birth control, does that impact the endometrium? So the way that birth control works is it's continuous exposure to estrogen and progesterone. But the estrogen dose in birth control is pretty low, so your lining of your uterus doesn't thicken very much. Estrogen is what thickens the lining of the uterus. Progesterone is what supports the pregnancy, and then when you are no longer exposed to progesterone, that withdrawal bleed occurs. So if you're on estrogen with a lower dose, then lining will not get as thick. And if you're taking estrogen and progesterone at the same time, the progesterone keeps the lining from becoming too thick. This is an actually very important concept for people with polycystic ovarian syndrome. And it doesn't scare me that birth control yields a lighter period. That is actually an indication for it. So people with heavy periods, we put them on birth control to reduce their bleeding. And that also doesn't impact the implantation potential in a frozen embryo transfer cycle, with the exception if someone is persistently having a thin lining, then I need to do some further investigation to understand why their lining is thin without being on birth control. I need to put a camera in. I need to see if there's scar tissue. I need to see if there's infection or inflammation or something else going on that would be causing a thin lining. But if the lining has thickened appropriately when exposed to estrogen alone, even with use of birth control, that does not concern me about embryo implantation potential. Let's talk a little bit about Clomid challenge test. This is something that is more of a historical approach for fertility treatment. We're not doing Clomid challenge tests as frequently now. Now, it's a way of functionally testing how much the brain has to yell at the ovary to get the ovary to do its job. So Clomid is a category of medications that we call a selective estrogen receptor modulator. So basically it tricks your brain into thinking that the ovary is not responding when the brain is releasing the FSH or follicle stimulating hormone. This hormone is what grows your egg of the month. And so if we take Clomid and FSH pops up significantly after taking it in the Clomid challenge test, we're concerned that the egg supply is reduced, our ovarian reserve is diminished because the brain is overly sensitized and has to really yell at the ovary to do its job. Now, other individuals, once the estrogen starts to come up from growing an egg for the month, the FSH level will drop down. And so for people that have more robust egg supply, that level drops down. Now, some individuals are still doing Clomid challenge tests for insurance purposes. Some are doing them for diagnostic purposes. But I would say we've moved more towards an antral follicle count gynecologic ultrasound, as well as a single blood test called an anti-Mullerian hormone that could be drawn at any point in your menstrual cycle. Here's someone wanting to know a little bit more about fertility preservation and family planning. A 36-year-old with no imminent plans or desire to achieve pregnancy on their own and wanting to know whether or not they should freeze eggs or just wait until the time comes. And if IVF is needed and egg freeze is needed, does insurance cover it or are they just out of pocket? And let's tackle the insurance component first. It's quite variable. I have some patients that their insurance policy is fantastic and it covers egg freezing, it covers IVF, it covers everything. Other insurance policies cover just diagnostic testing to see what your egg supply is and where you're at. And other policies don't cover anything. I would encourage you to contact your insurance agency, check what your policy covers. And I know we're approaching or have just recently approached open enrollment. So look at your covered benefits and see what those are and make the right decision for yourself. Some people use like a HSA account or things like that for their fertility preservation as well. And I would say at 36, depending on your timeline for your family building, egg freezing is a strong consideration. I would recommend that you meet with a fertility expert, a reproductive endocrinologist, and have your ovarian reserve assessed. That would be with an antral follicle count ultrasound and an anti-Mullerian hormone check. And that would give you an idea. Do you have a lot of eggs left? Do you have a medium amount or a small amount? Now, if you're thinking you're going to try to get pregnant in 6 months, probably not worth freezing your eggs at this point. If you're thinking it's going to be 6 years, yeah, you should absolutely consider freezing your eggs, or you should think about considering third-party reproduction. That's things such as donor egg or donor embryo, because the average age of menopause is 50 and a half. And we actually lose the reproductive potential of our eggs about 8 to 10 years before we go through menopause, so in our early 40s. I've created pregnancies with people using their own eggs at 40, 41, 42, 43. I've had people try after 43, but not been successful. I think some of the oldest reports, and these are the exception to the rule, you know, these are the people that won the biologic lottery, are people 46, 47, 48 years of age. But when we're in this age category of the mid to upper 40s, greater than 95% of the eggs are generally expected to be genetically abnormal. Let's talk about genetic testing of embryos for a 35-year-old. So what we're looking is to see if an embryo has 2 sets of each of the chromosomes. We want half from the egg, half from the sperm. At 35, I mentioned about half of the eggs are expected to have extra or missing chromosomes. The scientific data doesn't suggest that this is particularly helpful for someone that is under age 37. That said, I do think of genetic testing as sorting. So if you're someone that's going through and we're going to have 2 embryos, then I wouldn't suggest that you do genetic testing of embryos because you have 2 embryos. Let's put them in one at a time, give them a chance to do their thing. If you're someone that in the end, you're expecting to have 20 blastocysts and half of them are abnormal and half of them are normal, yeah, I personally probably would do genetic testing to get rid of the half of them so that I can get to the right one first. I also think of that as being helpful if you're trying to consider your overall family size. So let's say you're 35 years of age, but we're trying to put enough embryos in the freezer to have multiple children. Well, genetic testing may help you better understand the reproductive potential of what you have in the freezer. It also could potentially be used for family balancing if you're hopeful to have XX versus XY and make decisions about what you move with for your next transfer. So I would say on average, most 35-year-olds don't need it from our scientific data. That said, I absolutely do have 35-year-olds that elect to do so because number one, they have really robust egg supply. They want to sort and get rid of the ones that are unlikely to implant or would be a miscarriage. Or I have people that really want a better understanding of the reproductive potential of what's in the freezer so that they can plan out multiple children and have those in the freezer for fertility preservation as well. Let's talk about IUIs. So IUI stands for intrauterine insemination. It's where you place a speculum in the vagina, use a thin catheter to feed it through the cervix and place sperm at the top of the uterus instead of the top of the vagina. This gives it a halfway head start out to the far end of the fallopian tube where sperm and egg normally meet. And an IUI actually isn't done on a specific cycle day. So some people may need it on day 12, some may need it on day 16, some may need it on day 14. But the goal is to perform the IUI the day of, but before an egg is ovulated or released. So sperm can live in the reproductive tract for 5 to 7 days with an ejaculate. After an IUI prep has been done for sperm, it can last for 1 to 3 days. And the egg itself actually only lives within the reproductive tract for 24 hours. So you ideally want sperm ready and waiting for when the egg is released from the ovary, whether it's with an insemination or IUI, or whether that's with timed intercourse. So it's really personalized to you. This could be done by ovulation predictor kit monitoring. This could be done with trigger shot. Trigger shots generally IUI 2 days later, ovulation predictor kit 1 day after that's positive. That's because you pee out the hormone a day after your body is exposed to it in the blood, whether that's from your brain or from the trigger shot. So that helps time things more specifically than just choosing a cycle day. Thank you for your feedback. I appreciate it. I appreciate the kudos there. It's always nice to have a good pat on the back for working hard to educate people. And thank you for telling me about your little cute kiddo from our team. As far as interpregnancy interval, usually from delivery of one child, not initiation of pregnancy, but delivery of one child to the initiation of the next pregnancy, we're looking at an 18 to 24 month range to reduce the risk for you carrying your next pregnancy, as well as risks for your next child, so that we make sure the placenta is functioning well, we don't have insufficiency, that we don't have preterm delivery or C-sections or things like that. I do see a little bit of a leveling off around 12 months leading into that. And really 6 months is the shortest duration that people are of markedly advanced reproductive age, and we're trying to balance the shorter interpregnancy interval with the increasing maternal risks. But we're happy to meet with you, talk about that timeline. Let's talk about I'm going to kind of go to the embryo freezing question. Is embryo freezing something I should think about because I'm almost 30? And I would consider that more of a fertility preservation question. And I would say in your early 30s is when we start thinking about fertility preservation. And the real question is, are we preserving embryos versus eggs, or a combination of the two? I will share my personal journey and my story, and I'm happy to talk about this and share it with anybody, but I elected to freeze eggs at age 33. I got married at age 25. I'm still married to my significant other that I froze my eggs with at 33. But for me, I felt like freezing eggs was a way for me to protect my fertility. And egg age, again, is the strongest determining factor for reproductive outcomes. Sperm is produced throughout the entire lifespan. So that's how Richard Gere, Hugh Hefner, everybody's having babies in their 70s and 80s. But really, egg quantity and quality is finite. And so for me, I felt like the egg was the most blank slate. It was something I was doing for myself to protect myself and my fertility. And you never know what the future's gonna hold. I am very happily married in a good situation, but you never know what tomorrow is going to bring. And I wanted to make sure those eggs were something that I personally could use at any point in the future. I would say, again, if you're thinking about fertility preservation, usually in your early 30s is a good range. At age 25, hopefully you're young enough that you're never going to need it. But this is time to engage with a reproductive endocrinologist, get your ovarian reserve testing done. That's to understand if you have a lot of eggs left, a medium amount, or a small amount, and then have a discussion with them about your family building goals and how that egg supply goes into your family building goals. You know, if you have someone that is a designated partner that you're like, I'm having a baby with this human, or I'm having no babies at all, then absolutely have their sperm assessed. Do your pre-pregnancy genetic screening so that you understand if you're at risk of having 25% of your offspring affected with a genetic illness or something if you both carry the same gene mutation. And do that testing and discussion in a personalized way with the doctor so that you get the right treatment, the right recommendations for you. Let's talk about hysteroscopy. They found severe scarring. I'm imagining this is inside of the uterus, and the individual has a balloon inside of the uterus. Would I recommend moving forward with a transfer? That thankfully they've got some genetically normal embryos for transfer, or would I go through an EMA testing first? I think as long as the uterus looks healthy, I would suggest that you move forward with embryo transfer. Again, the EMA ERA data is somewhat limited in its benefit. I think it can give data, but I don't think that our larger clinical studies are revealing that this is clearly helpful. I'm glad that you got that scar tissue removed. That's fantastic. And hopefully they're going to reassess and make sure everything looks good once they get that balloon out. Now, when we talk about scar tissue inside of the uterus, often we don't know what causes it, but we do know there are increased risks for forming scar tissue. That would be things like infections or inflammation in the uterus. So if someone had endometritis, that could be it. Surgery to the inside of the uterus. So the biggest risk factor, I think, is when the muscle portion of the front wall of your uterus touches the muscle portion of your back wall of your uterus, then they have a risk of gluing together. Normally you have your endometrium, which is your lining in the middle that keeps your front wall from touching your back wall. This patient right now has a balloon to keep those walls from touching each other and scarring down. But for people that had extensive surgery, like a very vigorous DNC, or they're having a postpartum hemorrhage and people are trying to remove placental parts just to save their life and stop the bleeding, or if they had multiple fibroids removed from the front and the back, those are things that can cause an increased risk for the muscle touching the muscle and scar tissue forming. That said, I don't know what caused your scar tissue. So I think that, again, that's something that you want to discuss with your doc and see if there's something that is reproducible putting you at risk that could be treated, or if they think that they've removed that risk moving forward. Let's talk about PCOS. I have PCOS and you're young, great. You're 28, been trying to conceive for a year and a half with no protection before that, and was told to lose weight and lost 45 pounds. Good for you. Good job. That's awesome. And then has tried using progesterone on day 15, which will help you induce a period, but doesn't necessarily increase ovulation. The weight loss is what the goal was to induce ovulation. Even 5 to 15% of weight reduction can lead to ovulatory or regular menstrual cycles. And now this person's been on letrozole for 6 months and started talking about IUI and what do they need to do to make this happen. So I would say, you through your hard work, your great effort, and then a combination of that, as well as the medications, you've moved more from anovulatory infertility, which means not releasing an egg, so not getting pregnant, to a subfertility, meaning, hey, we've treated the ovulation component, but we're moving more towards an unexplained component, where 80% of pregnancies that are achieved are generally achieved within the first 6 ovulatory cycles. So if someone hasn't achieved a pregnancy after 6 months, I'm usually sitting down and talking with them and being like, I think if sex at home was going to do it, we would have done this by now. We would have been pregnant. And so at that point, that's when we start looking at all the other parts and pieces beyond just ovulation. We're like, well, do we actually have sperm? So people can ejaculate, release fluid, and not have sperm in it, not know unless I'm putting that under a microscope to confirm. Or double checking to make sure I have at least one fallopian tube that's open. And then if we have all the parts and pieces and they're all perfectly normal, then I'm thinking about adding an intrauterine insemination on as part of treatment for more of an unexplained diagnosis than an anovulatory diagnosis. Last one, very timely. Thank you for this question. And last one that I'm seeing up there is getting nervous about the holidays coming up, and nosy relatives. We've all got them, unfortunately, being around lots of kids, lots of family members, people asking the inappropriate questions. So this is really your time for self-care. And I think it's a time to communicate, if you have a partner, with them about your boundaries. I think there is a good kind of like safe phrase, like, let's go eat Cheerios means I've had it up to here. I need to get out of the room. Let's go do something else. So figure out your phrases, figure out how you're going to approach the nosy family member who's like, so when are you having kids? And for some people, it's just avoiding the question. For other people, it's a witty comeback that's like, well, I don't know, when are you having kids, or something that works for them. I think having a good plan in place for how you're going to approach holiday cards, because we all get the mail, we all get the like beautiful holiday family photo from all of our friends and family members, and thinking about how you're going to approach receiving them, as well as whether or not you're going to consider sending them. I think setting boundaries and communicating those boundaries in advance can absolutely be helpful in communicating with friends and family. I think working on trying to develop some new holiday traditions outside of kind of the same old, thinking about putting yourself in situations with self-care, being gentle with yourself, being gentle with your partner. Sometimes giving back is helpful. Some people like to do charitable events, and that kind of helps fill their cup. And I think just thinking about what you need for your mental and personal health and what your partner needs, and being very open and communicative about that. If you're going to any type of plays or religious events or anything like that, maybe choose ones that are not as kid or family centric. But do the things that fill your cup, and then also rely on your resources. This is when you're going to plug in. We've got a great resource center here, Utah Infertility Resource Center. Boston IVF has a great resource center as well, but plug into your mental health counselors, plug into those people that help fill your cup, and take good care of yourself. And honestly, in many respects, don't feel guilty for saying no. It's okay to say no. It's okay to communicate that you're not up for something. You don't have to explain why. You don't have to apologize for it. You've got to take care of yourself and your partner first and foremost. I'll give it a few more minutes in case any other questions are rolling in, or if there's anything else that people want to tackle today. But really, thanks everybody for your time. I know this infertility journey is a roller coaster. There's ups, there's downs. It's exhausting. Talking about fertility in the holidays, we know that infertility carries equal emotional distress to a diagnosis of cancer. So as you're trying to be kind to yourself, your partner, think of how you would want someone to approach you if you had a diagnosis of cancer, and you would expect people to be compassionate. And it's okay to expect that for yourselves now. And it's okay to take care of yourself first and foremost during the holidays. And please reach out. We're happy to help anybody here at Reproductive Care Center. We welcome you with open arms. We're a very a family and team environment where we all just want to see you have the success that you are so hoping for. We're going to hold your hand through the journey, answer any questions. We have our own patient portal. We have Connect, which is a chatting or texting that you can message us through. Myself and Dr. Blauer are happy to see and treat anybody. And we have 3 amazing nurse practitioners, Barb, Heidi, and Becky, who you will just fall in love with. They are so compassionate and so caring. And really, I just want to support each of you through your family building journey. If you're not getting your needs met, communicate, and find those people that help you fill your cup. All right, I think we've stopped rolling in with questions. If you guys need anything, I'll catch you on the next live discussion, and have a great holiday season. Take good care of yourself, do some self-love, and have a great day. Bye.